Hello, 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 and welcome to Celebrate Life Cancer Ministry and Celebrate Life Today with Pastor Rhonda, your host. I thank you all for joining us today. And today we have with us Dr. Marcia Ciccone. Hello, Dr. Marcia. How are you?
I'm good. How are you?
I'm great. And so before we get started in our conversation today, just wanted to tell you a little bit about Celebrate Life Cancer Ministry. We actually began, I guess we could say we began when I began my cancer journey, and which actually began in 9/11, which this year will give me 20-year cancer survivorship from inflammatory breast cancer stage 3B, 40 years old, and my first mammogram. Wow. And the only reason I really got the mammogram was because all my friends were getting one and they kept telling me I was too young. You're just a little kid. So because of that, I wanted to go and have mine. And my very first one, I was diagnosed with inflammatory breast cancer. So nonetheless, as I went through that journey, it took a year and 15 days with I had a lumpectomy, 6 rounds of chemo, a mastectomy, 4 more rounds of chemo, and then 25 days of radiation. And when I finished that, I said, you know what, it's time to throw a party. And that party turned into an organization called Celebrate Life Cancer Ministry. And we actually provide monthly support group meetings, home and hospital visitation, treatment buddies, telephone buddies, hospice support, as well as health and wellness education. And that's why we're here today. We've launched our TV show here on the Hope Broadcasting Network just 2 months ago as a component for us to be able to share across the nation. And for that reason, I am happy to have Dr. Marcia here with us. And so, Dr. Marcia, why don't you just go ahead and get us started with this great conversation?
Thank you, Pastor Rhonda. That's an amazing story you have, and some evidence kind of to segue into what we'll talk about today about how screening for cancer really does make a difference, and you're living proof of that. So that's an amazing story, and thank you so much for starting this organization and providing this support for cancer patients. I think it's very needed and very valued service.
And as much as I would love to see it go away, that hasn't occurred just yet. But I look for that day when they say there's no more cancer.
That day would be great.
So we're talking about cervical cancer and gynecological types of cancer. Maybe even some that few folks didn't think existed.
Yeah, so basically kind of an intro to who I am and what I do. I am a gynecologist, technically a GYN oncologist over at Keck Hospital of USC. I work out of County USC, out of Keck Hospital, and out of Verdugo Hills Hospital, sometimes out of Huntington. And basically what a gynecologic oncologist does is treat all gynecologic cancers. So that does not actually include breast cancer, but it includes cancer of the cervix, vagina, vulva, of the uterus, and of the fallopian tubes and ovaries. So that's kind of our domain. We end up doing surgeries for these cancers, and we end up doing treatment with chemotherapy for these cancers as well. And we end up following patients kind of throughout their treatment course. And then hopefully after they're done with their cancer and they're just being followed after they've been cured, then we do that too. So that's basically kind of my area of expertise. And today, as you mentioned, I think we'll focus down from that a little bit and talk about cervical cancer, because that's something that is very prevalent in the population. What it is, why it happens, and what can we do to prevent it from happening, because it is one of the big preventable gynecologic cancers. And what really matters in preventing cervical cancer is being educated about what causes it and making sure you get your screening in the right intervals and at the right times. So cervical cancer, the vast majority of what we see, and by the way, cervical cancer is the most prevalent cancer in the world. In third world countries, it's really hard to screen for cancers adequately for cervical cancer. And they don't get pap smears with the same frequency that we're able to get in this country. And so it actually is the most prevalent GYN cancer in third world countries. In the United States, and in other more developed countries, because we have screening, it's not the most common gynecologic cancer. Actually, uterine cancer is. So that right there is kind of evidence that screening really does help prevent this cancer. So where does cervical cancer come from? Pretty much all of the cervical cancer that we know of is caused by the human papillomavirus, which is a sexually transmitted virus. And I like to tell my patients when they get diagnosed with this virus, because this virus is very prevalent, that human papillomavirus, or you've probably heard it called HPV, is the short word for it, is kind of the common cold of sexually transmitted diseases. So if you've had sex, you've probably had HPV at some point in your life. Everybody, more or less everybody has had it at some point. It is like the common cold, it's a virus, right? It's transmitted by sexual contact. So any contact between two surfaces of skin can transmit the virus. The most common place where women are infected is on the cervix, but it can also cause infections in the vagina and outside on the vulva. And it can also cause warts in other areas of the body. So HPV can cause both genital warts, and then it can also cause cancer. It can also cause throat cancer, interestingly enough. So there are multiple different types of cancers that HPV can cause. And so this virus that everybody has or has had kind of can come and go. It's something your body can fight off. But it takes a lot longer than the common cold for your body to fight off. So most people will have it for 6 months, a year, 2 years, and then develop immunity and then fight off the virus.
So do we know we have it if this is going on?
Well, that's a good question. So for the most part, no. There's actually no HPV screening test for men. So men get it just like women do. And the only way a man would know if he had HPV would be if he had genital warts and, had physical evidence that there was HPV there. But there's no swab test for men. So it's not like gonorrhea and chlamydia, you can't diagnose it that way. For women, when we do pap smears, we can run an HPV test as well. So there actually is an approved HPV test for women. And we do pick it up in pap smears. And that's how we know if HPV is there or not.
So do they ask you, or do you have to ask to have an HPV test run?
You'd have to ask for one, and it's actually incorporated into part of the screening for cervical cancer that we do with pap smears now.
Okay.
So most doctors would not do it really outside of those guidelines because there's guidelines for when you screen. Okay. Because it's so prevalent, we don't even want to test women who are under the age of 30, because in general, women under the age of 30, maybe haven't found their partner that they're going to be with long term, and maybe having sex with different people, and that's just kind of what happens when you're younger. And so, we anticipate that in the younger population, there will be higher rates of HPV. And the vast majority of those infections, because the women are younger and have very healthy immune systems, will clear and will not cause problems. And some of the preventative procedures that we do, if we do see HPV there, if we do see changes related to HPV, can affect the cervix and can potentially affect future pregnancies. So we don't want to be over-diagnosing and over-treating things that are going to, work out fine. And really, because persistent HPV or HPV that stays around for 5 years, 10 years, is the problematic kind, because the longer it's there, the more likely it is to cause precancerous changes and cancerous changes in the cervix and in other areas. So really, we worry about women who have been exposed to HPV or who have had it for longer, and those will be women in their 30s and in their 40s. They're typically the ones that are going to be getting these kinds of cervical cancers.
So if I went for my exam and it showed that I had it, would you ask me to come back in 6 months so that you could see if it's progressed? Or, I mean, but how do you know that it's been there that long? It's like, why would I want that long?
Right. No, nobody would want.
Am I not transmitting it back and forth with other people?
That's the other problem. You can be transmitting it back and forth. So this is why, in general, it's a good idea to use condoms, because while condoms will not prevent all HPV transmission, it will prevent some. The other kind of big thing that we have in this battle against cervical cancer and against HPV-related cancers and diseases is the HPV vaccine. So this is a huge, huge thing, and I am a huge proponent of this vaccine. The HPV vaccine protects against 2 strains of HPV. There's a bunch of different kinds of the virus, just like you hear about the coronavirus now, right? And there's all these different subtypes. Well, there's all kinds of different subtypes of HPV too. So there's 2 strains that cause genital warts, and then there's a bunch of strains that cause cervical cancer. And so this HPV vaccine's been out for about, I want to say 11 or 12 years now. It used to be that only women up until age 26 could get vaccinated, but in the last few years, they've expanded the recommendations up until age 45. And women and men can get it. So that's kind of a good thing. At least one way men can prevent transmitting it to their partners or getting it is by getting the vaccine. And just a little segue into the men's section of things, it is important, I think, for men to get vaccinated because they can transmit the virus, which can pose a risk to their partner, but also for their own benefit. As I mentioned, this causes throat cancer, and in very rare instances, it can cause penile cancer. So there can be effects with men. And like I said, genital warts, men are not immune to getting genital warts. And so I think it is important for men to be vaccinated as well, but probably more important for women. So
and I think it's really interesting that they stop at a certain age.
Yeah, I think I'm really glad.
If you can't contract it later.
Right. I'm really glad that they moved, and this is the way science works, right? Like the same thing with the COVID vaccine. At first, they said, no people under 16 can get it because they didn't test it on that population, and now they're testing it on younger populations. So I think with the expansion of testing and with the kind of expansion of science, they start thinking about things in a broader sense. And just like you said, people of an older age can get this too. And so I think it's really good that they've expanded the rules so that people can get it later. One of the things they think about is, once you're older, you've probably already been exposed to it. And this is a, rule of probabilities, not a rule of absolutes. You've probably already been exposed. And so the benefit of the vaccine is not as high. And your immune system's not working as robustly as it was when you were, 15 or 20. And so the benefit, the response that you would have would not be as great. So that's kind of where that rule comes from. But still, I am very glad that they expanded the recommendations to at least 45. So we can try to catch people sooner rather than later.
Okay.
So that's the good news of that. So HPV vaccines, give it to your children. It's on the CDC guidelines for vaccinations. I believe for young women, it's like age 12 to 14 when they're supposed to be getting the HPV vaccine for both boys and girls. And the goal is to get this vaccination to children before they are sexually active so that it prevents them from ever getting HPV and thus prevents them from ever getting cancer. I will say that
all cancers are just gynecological.
Just HPV-related cancers.
Got it.
Yep. And I will say that the vaccine, although it covers a lot of the strains of HPV, it does not cover all of the strains of HPV. So it covers the most common ones that cause cancer and the most common ones that cause genital warts, but it's still not an absolute in terms of, you never getting HPV. So I think that's an important thing to realize. And then for that reason, we still need to have our pap smears, and we need to make sure we're getting those at routine intervals and coming in for those so that one, a gynecologist can check on you and, do an exam, check you for other signs of other cancers like endometrial cancer or ovarian cancer, and then do your pap smear, which is basically a screening specifically for cervical cancer.
Wow. That's a lot to remember. So my next question would be, how do you even know, outside of genital warts, how do you know that something, when you should go to the doctor because something is wrong?
So I think anytime you have problems with your period, so if your period is irregular or your period is very heavy and you're getting dizzy or you're getting anemic, or if, say, you have spotting or bleeding between your periods, and I'm not talking, a lot of people say, well, I have an irregular period because it comes at, a different date during the calendar month every month. But, your period should come at a regular interval, meaning every 24 days, every 28 days, every 31 days. For different women, that length of time between when that period starts is different. And of course, if it's every 24 days, it's going to be at different dates on the calendar month, right? But it's still going to be every 24 days. And there are apps that you can download to track this if it's, something to keep track of. I think even the regular Apple Health app has a menstrual tracker that you can follow. So it's nice to keep track of those things. And if something's off, it's always worth coming into your doctor to check that out, because that can be a sign that something's wrong. Usually that's not cancer. But as you get older, that risk may go up. And when I say bleeding problems, any bleeding after menopause is worrisome. So perfect follow-up here. What about if your cycle has stopped? Any bleeding after menopause or after you've stopped having periods is worrisome, and you should see the doctor right away. In my book, that's cancer until we prove it otherwise, just because it's a risk, and it's a much higher risk after you've stopped having periods.
So when you say if you see anything irregular, see your doctor right away. So right away does not mean at the next scheduled appointment 6 months from now.
No.
That means call urgent care?
Not necessarily call urgent care, but call your gynecologist and schedule an appointment, or talk to them, right? So some of the bleeding, the doctor might just give you some oral contraceptive pills or something to regulate the cycle. And then if that doesn't work, then you need to, be thoroughly evaluated. But definitely talk to your doctor about what's going on within, several weeks to a month. I wouldn't wait longer than that.
And I think we were, a group of women were talking not long ago, can adults get HPV? That was a big question.
Yeah, definitely anybody can get HPV. So even though we've restricted, the vaccines, unfortunately, to 45, anybody can get HPV. You can be 80 years old and get HPV. I think there's probably less HPV circulating in the older populations, but that doesn't mean that that's not possible.
Okay. So we were talking about prevention. So how do you prevent gynecological cancers?
Here? That's a big question.
Okay.
That's okay. Well, so we talked a little bit about prevention with the HPV vaccine. And we don't have all the data on exactly how much cervical cancer that's preventing, because it takes a long time to kind of follow that out. Cancer prevention, in addition to getting, to having your HPV vaccine, we started talking a little bit about pap smears. So for cervical cancer, pap smears are also pap smears are vital, right, to preventing cervical cancer. So the other goal in prevention is that cervical cancer tends to progress through a precancerous phase before it gets to cancer. And so if you can catch it and treat it in that precancerous phase, then technically you're preventing cancer from developing. So that's kind of the second part of cancer prevention, and the reason why your pap smear is really important. So when you go to the doctor, your pap smear is more than the doctor just putting in the speculum or the duckbill device that kind of opens up the vagina. It is the actual scraping of cells off of the cervix. So you can have an exam without having a pap smear. So it's really important to know what the doctor's actually doing when they do your exam. The pap smear.
Okay, wait, I'm sorry. I don't think I ever separated those two before.
Yeah, a lot of people
don't. You can
don't.
have an exam without a pap?
Yeah, a pap smear is something that you do during the exam, but it's not necessarily always part of the exam.
What's the difference?
So an exam, a gynecologic exam, is anytime the doctor looks at your cervix or feels your pelvic organs with their fingers. So when I do a pelvic exam, I will first put the speculum in, which is the duckbill instrument, to look at the cervix, and I just look at it, right? That's an exam, just looking at it. And then I would do an exam with my fingers. Usually I'll put 2 fingers inside the vagina, 1 hand on the abdomen or on the tummy to feel how big is the uterus, and I'm feeling how big are the ovaries, is there a mass there? So that is kind of the screening that we do once a year, and we recommend that exam once a year just to make sure that everything feels normal and normal size. And that has very little to do with cervical cancer, but in that way we can decide if there's, masses, or screen and talk to the patient and see if there's any problems with their period or things like that. So that's the exam. The actual pap smear is when we take a little spatula and scrape cells off the cervix. So it's actually a sample from the cervix that is the test for cervical cancer.
Got it. That's clear.
Okay. So we take that test, and we don't do that test every year on everybody. If you've never had an abnormal pap smear, the recommendation is to start at the age of 21, and you do pap smear once every 3 years, and you just do a pap smear, no HPV test, until the patient is 30 years old. At the age of 30, you can either keep doing pap smears every 3 years, or you can switch to getting a pap smear and an HPV test together and do them every 5 years. Because we know that cervical cancer is caused by HPV. If that HPV test is negative, that gives us a lot of reassurance that things are okay and that it's safe to wait 5 years. And they've come up with these intervals, and I will advise you that these intervals change. Like every few years, they'll come out with some new bulletin that tells us that what we did before was totally wrong, and we're going to switch it all up. But the intervals may change, and your doctor may change that recommendation over time. But it still is really important to get those routinely. I mean, and as a physician, if you come in and you're worried about something, and you say, hey, my last pap smear was 2 years ago, but I'm worried and I want another pap smear, I see so many bad things as an oncologist that I'll be like, I'll happily do your pap smear sooner than that, just to kind of, alleviate stress if that is the case. But what we do with the pap smears, as I mentioned, we scrape the cells, right? It's a little different than a biopsy. When we scrape the cells, they kind of come off as these loose cells, and we put them in a liquid usually, and the pathologist takes that liquid with the cells and puts them on a slide and looks at them under the microscope. And the pathologist says, hey, are these cells abnormal? Does it look like there might be cancerous cells or precancerous cells? And they basically give us back a report that says, hey, there's something, either it's normal or there's some abnormal cells here, and they tell us a little bit more about what cell type that is. cancer often doesn't even show up as cancer on the pap smear. It just comes back as abnormal cells. So most of the time when there's an abnormal pap smear, we have to do a little bit more workup or a little bit more invasive tests or procedures or biopsies in order to know really what's going on there. So if your pap smear comes back abnormal, or sometimes if your HPV test is positive, we might recommend that you undergo a procedure called colposcopy, which is basically a really thorough exam of the cervix, and sometimes biopsies also. And these biopsies are bigger or deeper biopsies where we get the surface tissue and a little bit of the tissue underneath.
Underneath?
Yeah, a little bit of
like
the
at
tissue.
a deeper level?
It's a little bit deeper. These biopsies are still very small. They're less than a centimeter. But basically, just like you have skin on the outside, right, covering your whole body. And then if you cut your skin and you go a little bit deeper, there's a tissue deeper than the skin that's a little bit different tissue than the skin. Well, there's a thin layer of skin that covers your whole vagina and that covers your whole cervix. And just like kind of the inner part of your labia, it's a softer tissue, right? It's a pinker, softer tissue. That's the same kind of tissue that you see inside the vagina and inside the cervix. And so that tissue is just a layer of skin, and that's the tissue that actually gets cancer or that gets affected by the HPV. And then the tissue underneath it is a different type. And so what cancer actually is, right, is an overgrowth of cells that stop behaving themselves or stop staying in the place where they're supposed to stay, and they start going into places they're not supposed to go into. So cancer can only be seen when you see the whole architecture of the tissue. You see the skin layer and you see the layer underneath, and you can see if that cancer is going into that layer underneath or not.
Wow. That's why we need scientists.
Right. It's a lot, but that's kind of why the biopsy is different than the pap smear, and why the biopsy is more helpful for making that diagnosis of, well, is this cancer or is this abnormal cell layer just on the outside and not doing as bad a thing as cancer would be.
So you said, and help me on the terminology, you said a PAP doesn't start until 21?
Pap smears usually do not start until 21, yes.
And a younger person could get one only if there's trouble.
So usually the only reason I would do a pap smear in somebody younger is if they have problems with their immune system. So with patients who have HIV, and sometimes we use the same guidelines for patients who are on steroids or who are maybe have had transplants. So sometimes younger patients have had heart transplants or lung transplants or kidney transplants. And usually you're on medications to suppress your immune system because of the transplants. So if there's any known problem with the immune system, or if a patient has HIV, we will do pap smears earlier than that. We'll do it as soon as they become sexually active. Just because, right, this is a virus, and if your body can't fight it off because it's immunocompromised, it's more likely to cause problems than if you have a normal immune system.
Okay. Wow. Very well. So how do you treat, and I keep saying gynecological because you may come up with a treatment for a different type of cancer that we don't normally talk about. I know I actually had a person who was part of Celebrate Life who had vaginal cancer and went through the radiation component, and she could not, in order to do normal things, she had to be in a tub of water.
Oh yeah.
Because
she was getting radiation.
Mm-hmm.
Yeah.
That I can only cringe when I talk to her.
It's not good because they also radiate the vulvar, the outside, when they do radiation for vaginal cancer or for things that are lower in the vagina. They cover that whole area, and it's kind of like you have a burn there when they radiate you. So it can be very, very painful.
But is chemotherapy an option for those types of cancers as well?
So chemotherapy can be used. We often use it with the radiation to help the radiation work better. Generally for HPV-related cancers, for cervical cancer, for vaginal cancer, if it's not something that we can safely take out with surgery, or that we can get, all of our margins and get everything out with surgery, generally radiation is recommended as something that can cure the cancer. Chemotherapy for these types of cancers is not really curative. So it's not really an either or kind of thing. Usually the curative options are surgery or radiation, which is the reason why we do that preferentially. And we give chemotherapy in instances or in cases where we can't cure it or it's too widespread, because the radiation just acts on one area. So if the tumor's in one place, you can treat it with radiation. But if, say, you've got tumors in the lungs, in the liver, in the stomach, and in the cervix, radiation can't get rid of all of that, because we can't radiate all those different places. Or we can't radiate your whole body. So you really need chemo to get everywhere. And say you could radiate different places, when there's cancer in multiple places, that it's already in the bloodstream, it's already out of where it came from. And so you really need treatment that goes over the whole body to make sure you're treating those cancer cells that maybe you can't actually see, but could be in different places in your body.
Now, you talked about margins. Now, I know what that means, but can you explain to us why margins are so important?
So margins are the edges of the cancer that borders with the normal tissue. So whenever you do surgery and you take out or you cut out a tumor, you want to make sure you got the whole thing and you didn't leave anything behind. And, when we're doing surgery, we can only look with our eyes and see what looks like tumor and what looks like normal tissue, and go based off of kind of the naked eye and try to get everything and make sure we don't leave anything behind. If you leave something behind, the risk, of course, is that the cancer that you left behind is just going to grow back. So it's really important to get all of the cancer out. But cancer is just individual cells, right? So even if you leave a little cell back behind, that cell can grow back into another tumor or into the cancer again. And so what we ask our pathologists to do, because like I said, they look at everything under the microscope, is look at the very edges of the specimen that we give them, or the edges of the tissue that we give them. And they will tell us if the cancer is in those edges or not, and how far the cancer is from the edge that we cut. And that's called the margin. Like, how far is the edge of the cancer from the edge that you cut? So we want to make sure those margins.
Did you cut through any cells that it looks like it's not a full picture?
Exactly. Yeah.
Because I was like, how do you know that it's all of it? And so, and you continue to use the term cure. Mm-hmm. People use the term remission.
Right.
Then there's cure. Say that again.
Remission is probably a better word.
Oh, okay. So now and I've never even asked this question in my 20 years. Remission. Is that typically related to a certain type of cancer versus, like, I always thought it was like a difference between a blood cancer and a breast cancer. A breast cancer, or if you can go in and get all of the cancer, you can get all of the tumor and remove it, then technically, this is the layperson thinking, technically you're cured. Mm-hmm. But if it's a blood type cancer and it runs through the bloodstream, then it's a greater potential of being in remission, because it can truly come back, because you can't cut it out.
Yeah. Well, I think that's a good point to make, and I think your understanding of it is pretty good. It's probably more accurate to use the term cure when you're talking about a cancer that is more likely to never come back, right? Like in any early stage cancer, you can do the surgery, you can do the initial treatments, and a cure makes you think, oh, I'm done, it's never coming back, right? That's the implication that the word cure has. Whereas the implication of the word remission is, well, it's gone for now, we can't really see it, you're not getting treatment, but we're watching because it might come back, right? So any cancer that you treat that started off higher risk or that it's a higher stage is probably more appropriate to say the word remission. If it's something that we don't think is going to come back, we can use the word cure. I think the fact of the matter is that anytime you've had cancer before, there is a possibility that it can come back. Now, if it's been a super long time, like for you, it's been 20 years, I think you get a little more comfortable using the word cure because the likelihood that anything's going to come back after that, if it's been that long, is very low. Because if it was going to come back, it probably would have come back already. So, I mean, technically, I think for any cancer, if you've treated it, you're done with treatment, and you don't see any more cancer, you don't see any more cancer on scans or on exam, you pretty much say that cancer is in remission. But using cure is more accurate, when, like I said, it's been gone a really long time or it's something that's really unlikely to come back.
But being gone a really long time does not keep your blood pressure from going up when you go for your follow-up appointment.
Oh, no.
So we're always on edge about that. It's like, woo. And, in fact, there was a point where the doctor, the oncologist sent me to cardiology because my blood pressure was always so high, and they're like, what is going on? But when I got to cardiology, they started looking at my chart, and he said, do you realize that your blood pressure is really only high when you go to oncology? It's like, well, that's something, but that you have to look at the whole picture. Just like, some people will say, take their blood pressure every day, like, they've been requested to do that. But they'll say, well, it was high now, and now it's low, and that's high, and it's low. Well, what's going on in your life? What's going on in your world? What activities were you just doing? And, there's so many other things to look at. So
true.
All right. So is there anything else you want to cover before we say so long?
I think that's the biggest thing. I'll make a little plug for screening and for prevention for other cancers that we treat. So more like cancer awareness. We talked a little bit about abnormal bleeding already and why you should come in and get checked for any abnormal bleeding. I think the only thing that other thing that people should be aware of is ovarian cancer, which is kind of the silent killer, unfortunately. We have no screening for ovarian cancer, and we have, the symptoms generally don't show up until the cancer is already really advanced, which makes it a harder thing to treat and a harder thing to use the C word, the cure word. We tend to only use the remission word with ovarian cancer. So ovarian cancer symptoms are things like maybe gas, bloating, nausea, bad appetite, weight loss, constipation, just things that you feel a little off and you're not sure why. But definitely if you're having abdominal pain or bloating that won't go away, those are reasons to come see your doctor as well. I think the other important thing to realize is the genetic pattern or the way that some of these cancers, especially uterine cancer and ovarian cancer, can be transmitted through families, or kind of the I guess vulnerability to getting these cancers can be seen in certain families more than others. And so if you have other people in your family who have had ovarian cancer, or multiple members of your family with breast cancer, or if there's been a male in your family that's had breast cancer, there actually is genetic testing that can be done and genetic counseling that can be done to see if you have genes or an increased risk of getting ovarian cancer or breast cancer. And we can test for those things, and we can start screening earlier and do preventative things earlier to help prevent that from happening. So that's my plug for the rest of my cancers.
Yay. Very well. So if someone wanted to get in touch with you and to ask you any additional questions. Is your email on the screen correct for them to just send you an email?
That looks good. That looks correct.
So it's so wonderful to be able to have uh, doctors that you can email and they will answer you. So I think, a couple people were nervous when COVID began and they moved largely into telehealth.
Mm-hmm.
People want to be seen. People want to be touched and looked at.
Yep.
But there's a lot of things that, if you're telling the doctor everything that's going on, the doctor can ask you different things. Then there are many things that can be handled through telehealth, right?
There are, yeah. Telehealth has brought a lot of, I guess, access to people that maybe had trouble getting to the doctor, or they say they live far away. So it's been really beneficial in bringing that option for those patients.
And at least because I have emailed my doctor pictures of a rash on my hand. It's like, what is this? And rather than going in to see him and then he refer me to someone else, now he can just look at it. I just do the fast pace directly to the dermatologist.
Yeah.
And then there was no copay. Like, that was so nice.
I will warn that this email is only for general questions. If you have questions about yourself or your own health, I'm going to redirect you to your doctor, because I can't legally do that through this email, but I will answer any general questions that you guys have about screening and things like that.
Most definitely. I completely agree with that. Because people will ask anything like, this is mine. You don't have their chart. You don't have anything.
Right,
so
exactly.
You're right. Just general questions. So again, I would like to thank you so much for coming on and sharing with us, and sharing all this information, because I actually got information from you that I have not had in quite some time. So as we usually say, until next time, choose life. And we're signing off for Celebrate Life Today with Pastor Ron. Thank you, Dr. Marcia.
Thank you. See you later.